All right. Well, I have right at the top of the hour. So I am thrilled to begin today's webinar with you all. So again, thank you all for joining. I see many of you using that chat feature to just let us know who's here. We greatly appreciate that. Just want to welcome everyone and thank you all so much for joining us today for this very important and timely webinar on telemedicine services and some billing and coding updates. And so just again, this is a two-part series. So we will be looking at state Medicaid updates specifically for Alabama, Arkansas, Louisiana, and Mississippi today. Our other states will be represented next week. You're welcome again to attend those sessions. Repetition is a good thing in my book, but this is a two-part series, and it is, as Caleb let us know, it's being recorded, and we will have this presentation on our website, and Caleb Lazinski will be sharing that information once it is posted to the website via email. Well, I hope you're all doing well. I hope that you find this very helpful. My name is Kim Mayo, and I am a program specialist with the DRCHSD program, which is providing today's webinar. And so again, you're using that chat feature. I love it. We're hearing from the folks who are here. Just let us know who's here and your name, your title, your organization, and that gives us a good feel of who is joining us today. And also utilize that chat box for we'll be monitoring throughout today's presentation. So use that for any questions or comments you may have along the way, and we'll relay those messages to Heather. The next slide is going to tell you about our funding. So the DRCHSD program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. And the next slide gives you an idea of next week. So next week we'll be talking about Tennessee, Illinois, Missouri, and Kentucky. So we'll be finishing out the series. And then I did want to just highlight an upcoming quality improvement series that will be starting in April and running through mid-May. So you'll be hearing more information about that very soon as well. ACHE credits are available for today's webinar. In order to gain those ACHE credits, Caleb Lazinski, again, will be sending an email at the end of the week, and then next week, with a survey link that must be completed in order to obtain those CEUs. And before I introduce our speaker, I believe we have some pre-polling questions. And Caleb will share those. All right, so you can complete the pre-polling and you just click on however you feel about the question of your understanding of updates that were made to the telehealth billing and reimbursement guidelines due to the COVID-19 public health emergency. So Caleb will let that run until he feels most are complete. And in the meantime, it is my pleasure to introduce Heather Green. Heather is a member of BKD's Healthcare Performance Advisory Division. She has nearly 20 years of experience in the healthcare industry with extensive experience working in a variety of key healthcare information management roles. She works with hospitals in evaluating, sorry, my screen slide, in evaluating and, let me find myself again here. So sorry about that. Evaluating and improving their clinical documentation and integrity programs. She provides coding and documentation training to improve clinical documentation integrity and coding accuracy. She is a registered, this is a lot, this is very impressive. She's a registered healthcare information administrator, certified inpatient coder, certified documentation improvement professional, certified professional medical auditor, and certified professional coder. She holds designations of approved CDI and IC10 M/PCS trainer. And so as I turn things over to Heather to start our presentation today, please remember to use that chat box for any questions. And I believe we're going to stop sharing, and Heather is going to start from her end. So thanks so much, Heather, for being here with us today.
Thank you. I appreciate it. And I'm working on sharing right now. So, when you have a number of years of experience and work in, a number of different fields, you just kind of collect those credentials to kind of come along with you. If you're going to go ahead and do the learning, you might as well get the credential to show you learned it, right? I did want to point out one of the things that doesn't really come out in my bio is that when I started, just a couple of years ago, when I started, first off, I was in the office. I was in a physician's office, but then I moved over to a critical access hospital and worked a number of years in a critical access hospital. So I definitely understand for most of you all that are in that situation. I've been there and I've worked that. I know what it is. And so I understand that it can be sometimes difficult to get resources or just have the time to keep up with what's going on. Especially right now, the one thing I can say is I did not work there during a pandemic. So I can only imagine what you all are going through as you all have tried to survive and, and work through the COVID-19 pandemic. So with that, we do have another disclosure where we're saying, it's COVID-19 and everything is changing. Even coming out of COVID-19, everything is changing. And so I think it's going to be new for us again to come out of a pandemic the same way as it was new for us to go into a pandemic. And so with this, when it comes to your payers, your states, yourself, give grace, because we're all trying to figure it out. And it becomes evident when you're researching this to find out what's going on. My slide's working here. Oh, okay. So things we're going to cover today is what happens after that PHE ends. What are we going to go through? Some general information. As I was researching, I found some information that was very, very helpful to me. And I wanted to pass that along because it gives you a foundation for where to look when you're trying to find out things. And then we're going to talk about mental health specifically, because there have been some changes for that has come out as a permanent law. And then we're going to talk about some of those updated billing guidelines, telehealth and virtual communications. We'll be talking a little bit about telehealth versus audio and billing and reimbursement, and then our questions. So first and foremost, I thought everybody would like to know, and you probably know in your states, but when did your state PHE end, or when will it end, right? So right now, Medicare is set for the PHE to end April 16th, 2022. That's a month away. With that said, word on the street is it's going to be another 90 days after that. And now knowing that there is a Delta Omicron variant that is coming around, likely we're looking at that 90 days. But we will not know that until April 10th. And so you really have to be ready now as we're trying to move out, being prepared, because unless there are new laws written, everything will revert back to pre-COVID regulations. And so that is very important to understand. And when do you move back? So keeping up with that, dates here are going to be important. Alabama, you all are set right now for the state PHE to end on March 31st, so the end of this month. Arkansas, your all's ended back in September. Louisiana, you're looking at yesterday. And then Mississippi, you again ended back in November 2021. So as you can see, the state PHEs, and really there's a lot of things that come into play with that, but for the states, it's it's the ability to be able to call in the National Guard. There's all kinds of reasons why a state wants to have a PHE and if they don't want to have a PHE. So, and depending on the state, the governor and how it's ran is how those decisions are made. It's not necessarily obviously geared towards healthcare. Still, for us, in terms of payers and our Medicaid, we do need to see what's going on with that. I found this slide when I was going through and doing research, and this is from the CCHPCA. So they work with telehealth and they are promoting that telehealth modality. And they had a slide to this, and I have adapted it pretty closely for to match this. So when Medicare is making policies, there are 4 elements that have to go into a policy. And you ask, why is this important right now? Well, because policies are changing like every day while we're trying to figure out how to come out of this policy. So there are 4 elements to a policy. So we have service, which, what services can be reimbursed. Then we have patient location. Where's that patient located? Are they in state? Are they out of state? Are they in what originating site are they in when we're talking about telehealth? Where are they at? Then we have modality. How can these services be provided? And then the provider eligibility. Who can provide what services? So 3 of the 4 of these light blue areas right here, these all require literally an act of Congress to modify. And so CMS does not have the ability to change this information. The only thing that CMS has control over is what services will be reimbursed. And so in terms of, we're waiting for Medicare, Medicaid guidance to come out on how to bill things and how to do things. They're waiting on Congress to tell us what, to tell us what can happen. Because so Congress has to tell Medicare, Medicaid, and then Medicaid and Medicare will tell us what we can do because they're going to make the services. And so when you're out there looking and you're trying to figure out how to figure out if you're an eligible provider, if you're able to do these things, that you have to go to Congress. We have to look at bills. We have to see where those bills are at in the process in order to understand, what's coming down the pike in terms of that. Going on. So one of the things that happened in terms, we have 2 things. We have the CAA that was passed. And so that is a permanent law. I have this with apostrophes around it because it's still not permanent yet because we're still in the PHE. So when the PHE ends, this does become permanent. And then what we have here in this last column is the physician fee schedule. And so what happened in the CAA is that it came across that mental services can be provided in the home without meeting geographic requirements with certain limitations. And so if you've listened to anything, been able to, that there is the 6 month, they have to be seen in person within 6 months. And then there has to be that annual visit in person after that. Here in the PFS changes, what they've done is and the physician fee schedule is Medicare. So they require this information, that 12, what we just talked about, that 12-month annual visit. They are going to allow audio only for mental health services. Again, those certain criteria have to meet that. So in terms of us and HIM and administrators, how are we going to document that? How are we going to retain that information? How are we going to be able to pull that up very easily when we're asked to prove that we're meeting these caveats? So when you're working through your plan, how are you going to do that? Also, in the physician fee schedule, they are going to allow FQHCs and RHCs to provide that mental health service via live video or audio. Again, those same caveats coming into place. And then what they also said is that we have certain COVID-19 telehealth services that, we allowed, Medicare allowed during the PHE. They're going to say they're going to remain for 2 years. So until December 31st, 2023. That is not specific to FQHC or RHC, just so that you know. Not everything came over. There's about 60 services or so that are still going to be eligible for this 2-year extension. So make sure that you understand where to go to find that and look for that. to know what it is. And here's your site for that. So what you want to do is go in and look at that physician fee schedule. I've got the link down here, and this is what you're going to look for, is a list of the telehealth services. One of the things when I was reading all of these new regulations and codes is they were talking about these categories. And so from CMS, the site also tells us what those are. So category 1, I mean, these are evaluation and management services. This is things that are very similar to that, things that really can happen, you know, when it's face-to-face, but you can actually do that. Telehealth is too. Category 2 are really those things, they're kind of everything else. So really, can you do those things, telehealth service or not? And so what CMS is saying on these, and these are some of those are actually in this category, but they're going to look for some really serious information. And these are ways for you to propose that this should be a telehealth service, but they're going to want to see it reduces readmission. It reduces the recovery time. It may help reduce complications. So if you have a service and you're like, man, this really could be done telehealth, you're going to have to be able to prove the clinical benefit of it. And they're pretty hardcore about that. It actually goes into more detail on the website. So if you have any services like that and want to send it in, make sure you're following that. And then these category 3 truly are the ones that are added during the PHE. And CMS is actually seeing that they do serve benefit. And now they're saying this requires more research. So they're going to take a look at these, and they're given 2 years. They're going to do some studies on it, and they're going to see, again, if they're going to be able to meet that high standard to show the benefit of it being telehealth. So I think understanding that, and when you're reading these regs and you're trying, what's category 1? Of course, I went right to the CPT book going, okay, oh, no, not. So, you know, making sure that we're talking the same language that we're talking when we're looking at the fee schedule. So taking a look directly at mental health, when we're looking at that, prior to the PHE, CMS would reimburse only if it was qualified practitioner furnishes services, if a practitioner was located at a qualified distance site, so only certain facilities, right? The patient presented at a qualifying originating site. So they had to be at the FQHC at the skilled nursing home. They certainly couldn't be in their home. And then the parties used technology that permitted a two-way real-time interactive communication complying with state and federal laws. And so some of this has changed as well. So this is pre-COVID. This is, until this is updated, this is the law when PHE ends. So we would revert back to this. So understanding that, again, the caveat is unless a bill is passed, and there's probably 20, 25 bills out there that are working to go through. Hopefully one of them will get through. So we'll see, but right now we would go back to this in telehealth services. And so if you have an FQHC and RHC, if you're providing those telehealth services, understanding that if this doesn't change, this is what we would revert back to. And how are we gonna handle that? What is that operation going to look like if we do that? So also with mental health, CMS has significantly relaxed the reimbursement criteria for the mental health telehealth services. They have put out a lot of information. They are showing and they are seeing, I guess for lack of a better term, the return on investment, the clinical benefit of allowing patients access to their mental health providers on a real-time basis, and not allowing transportation or other very common barriers to keep them from their provider as needed. Again, here are those caveats listed out, and this is in the physician fee schedule. So right now, this is a permanent law, but does not take effect yet because we are superseded by the PHE. I'm hoping that I'm saying that correctly and everybody can understand what I'm saying. So after the PHE, for mental health services, this is what the rule will be when it comes to it. CMS has also said the patient location may be outside of that qualifying rural zip code. And they will also allow audio only when the patient home serves as the originating site and the provider has audiovisual capabilities. However, the patient either does not have that capability to do it, or they do not consent to be on video. And so making sure that you have that documented is going to be extremely important if you're audio only. Again, with these are caveats. And if you look at this and you think back to the slide that I showed you with the 4 categories, CMS has really gone out into the gray on this. I mean, they've really, stuck the stake in the ground and said, we're not giving this up. I mean, we might have to give up some things, but mental health is here to stay. So kudos to them for doing this. They have lots, and they are pumping out lots of clinically valid studies that are showing the benefit of it. So CMS is really on our side, on the patient side, in terms of getting this access to healthcare. So they're pushing out data for us. And so getting that and having it available to yourselves and making sure you talk to your congressman, really important here. Moving on. So currently for the mental health, or, in the new rule, I should say that this is going to be new rule. This is how an FQHC, for those of you who have FQHC and RHC, how you are going to bill out those different services once the PHE is ended. And so making sure that you understand that and how you're going to be billing that out. Again, we have some modifiers down here, and we'll talk about that. We have that 95, which is audio visual, and then we have the FQ modifier, which is going to be the audio only. FQ is new in 2022. So, and we're not using it quite yet that I can find, and you all please in the chat tell me if y'all are already using it. I'm still waiting for the official language to come out saying, yes, this is what you do. So if you all are using it, I'd like to know if you all are. So again, and what they say in the, in the RHC and the FQHC, and what CMS is saying is you treat mental health as if it's a face-to-face visit. You bill it out as if it's a face-to-face. And if you go in and you read what they've already said to FQHC and RHC, they're saying that. So the idea of this is you're going to bill it out as if that patient walked into this door and you're looking at them face-to-face, except for you're going to use a modifier now to either say it's audio visual or you're going to say that it's audio only. So making sure that you're following that, that will help you out. When the PHE ends, the G2025 will no longer be an acceptable code. You will treat them as if they're in person when you're billing that out. Another thing that has changed, and this is, I think it's actually changed probably mid-year last year, is the replace of service codes. CMS has actually broken that down further. And then you're going to have to check with your states. What I've seen, most of them, they're actually accepting these. They're trying to stay consistent with Medicare. Some states have actually already updated and said, yes, we're going to do this. And some states are still silent, which again, we have to give grace because everybody's still trying to figure out what's going on. So we'll be waiting to see how this is coming down the pike for us. And the big thing is O2, place of service, is going to be when the patient is outside of their home. And 10 is going to be when the patient is in their home. Most or CMS and probably most of your providers are going to require prior authorization on a number of these services before you provide them via telehealth, or for that matter, if you are doing it in person. So making sure you understand when prior authorization is going to be required and when it's not. If you think about speech pathology, OT, PT, a lot of those already require a pre-auth. So if you're doing it via telehealth, you're likely going to still require those. So make sure that you're getting those pre-auths, because if you're not, you're kind of dead in the water in terms of reimbursement, right? So make sure you're understanding when that pre-auth is required. So here's a list of our telehealth modifiers. I absolutely love this little phone. I think it's absolutely adorable. Been a long time since I've seen one in real person, but here we are. So there's a couple of different modifiers, and they mix and match them in terms of if you're using them or not. So we do have the GT modifier. That's an interactive audio and video telecommunications system. And then we have the 95 modifier that says synchronous telemedicine service rendered under real-time interactive audio and video telecommunication system. And so depending on your state and how they define what audiovisual is likely going to be which modifier you'll be using on those audiovisual encounters. A GQ modifier is an asynchronous telecommunication system. That's going to be on a lot of your monitoring services that you may be doing if you have initiated those. Our FQ modifier is the new one that we just got through talking about. Again, this is real-time audio only is when you're going to pick that up. There's also a modifier 93 out there, which is synchronous telemedicine service rendered via telephone or other real-time interactive audio only telecommunication system. And then there's another one here that is for supervising. So this is going to be your when a supervising practitioner was present through real-time two-way audio visual video communication technology. So if you're in a situation where supervision is required for whatever reason, I guess what comes to mind for me is maybe off the top of my mind is ABA therapy, which you all may or may not do. But if it's it could be mental health, you could run into that. It could be something where your physician may be supervising an NP or PA, anything like that. Speech pathology, OTPT, there may be supervision that's required, which means you really have two providers on the call and one provider providing the service. So making sure that the supervising person actually puts that FR modifier if they're on the call or if they're in the service and they're in that encounter, showing that that's what they're doing. I wanted to stop there. That's an awful lot of information. Was there any questions?
No questions thus far. We have, you have a comment that is great news regarding some of the updates. And Kate has linked a form that if any of our current participating DRCHSD organizations would like some one-on-one telehealth billing and coding consultation support, that avenue is available as well. So that is in the chat currently. I don't see anything else, but that is a good reminder to, if you do have questions, comment, please leave them there.
Yes, it is very, very good news. I can tell you I was jumping up and down for joy. And then, you know, I was seeing some articles come out and I'm like, yeah, trust but verify. I was digging down into the rules. And, you know, when the Omnibus Bill came out, I was looking at it and what it actually says is that it says strike here at this sentence, do this. And I'm like, y'all can't just rewrite it for me. No, of course not. So you have to actually go there and then you have to go back to the original rule and you copy and paste and you put it in there. And I'm like, yes, we're good. So now I'm going to give y'all one more caveat. We have to get President Biden to sign the Omnibus Bill. That is another caveat to it. So layer on layer upon layer. So if you think about this, we have our pre-law, pre-COVID law. Then we have our PHEs that may have some state PHEs stacked on it in there too. Then we have another bill that's law now that is laid on top of it. Then we have a physician fee schedule ruling from Medicare that is laid right over here on it. And then we still have PHE on top of that. And so it can become a run-on sentence when you're trying to explain exactly where you are in this well-oiled, yeah. So even when you're trying to figure out where you're at in that layering and what are you doing? So the big thing you can think of is, you know, in terms of this is where are you going to go? How are you going to operationalize this? How are you going to make sure that you are maintaining and retaining the right documentation? It's not just about receiving reimbursement, it's about keeping that reimbursement. And the one thing that we do know is that hindsight is 20/20. And as auditors, we're working from hindsight. And you all in the field, you all are working in the moment and hindsight is not available to you all. So try, keeping some of these things in mind. I will say one of the things I'll add to this is that we do know the OIG has done some studies on telehealth. In general, they are finding that practitioners, you all, in terms of was a service done and was it, reimbursed and are you billing it correctly in terms of that one-to-one, they're saying providers are doing a pretty darn good job. Now, this isn't going into documentation and do you have your consents and are you saying where the patient's at and where it's not, but this is a service is provided, it's billed, it's paid. Okay, we're top level, high level, we're good. They did say that where they are seeing potential fraud is in those marketing situations. So that's not us. This is going to be maybe some of those places where you're calling in and you don't know who you're going to see, but you're calling in to see it. And I don't want to name names because I don't want anybody to think that anybody's doing anything fraudulent. But DME did come up. So they're saying like DME was ordered or charged and it was never received. So there were some things like that. It's probably not going to apply to you all. Also, OIG has said they're going to come out with 2 more reports this year. So stay tuned to see what they're saying. We do know that there are some documentation issues or topics that have caught the OIG's attention, such as what I just named, the consents. Are you saying where you are, where the patient's at? Are you clearly documenting that this was telehealth and not in person? So making sure that we're following all of those things and getting all of that stuff documented in the chart, extremely, extremely important, because that is where they can come back and say, okay, you're not meeting conditions of participation, or you're not, you should not have charged this because you didn't get a consent. Again, your pre-auth, those kind of things. So making sure that you're taking all of these moving pieces and putting it in here. Also,
are you ready for a question or would you like to continue?
Sure, go ahead. Sure, go ahead.
A question has popped up. It says, after the PHE, will the EM codes plus the FQ modifier replace the G 2025 code? Does that make sense?
For mental health, as of right now, for mental health. And I'm going to give me a second to stop for just a moment, please. Yeah, for mental health. Give me just a moment. I think I have an updated slide. Yeah, for mental health, the way that the law is written right now is for mental health. And just a moment. I apologize for this delay. We do have the Omnibus Bill that I did mention, and slide deck. Make sure I got the the Omnibus Bill that just came out has extended some of these services for 151 days past the end of the PHE. And so we need to, what that means is that 151 days is about 5 months. So we were talking about that the PHE ends currently April 15th, and you can add 5 months to that. April, May, June, July, August, September. As of right now, the PHE rules will extend for up until September 16th. If it's not kicked down the road, another 90 days, which would add it to 8 months. And then I'm trying to make sure I've got the right slide deck because I have this in here in that with that was the extension of not just mental health, but also, which is law now. It was also all the services that are already being provided. So anything that's happening in the PHE. So when the PHE is in effect, and if this Omnibus Bill is signed by Biden, it will be, the PHE will be in effect until 151 days after the end of the PHE. And I'm going to get there. We had an update last night. So that's what I'm trying to get to make sure I have the right one in here for you all before I move forward so that I can go over that.
Very understandable. I know that this information is ever changing, and so I think very understandable.
Okay. It's not showing up in here. Interestingly enough. Let me go back here. So with that, understanding the Omnibus Bill and going through with it is going to be extremely important because we're seeing it. Oh, here it is. Really? Okay. I apologize again for that. Let me share my screen. And this will help me make sure that I am getting you all of the information that you need. Share. Here we go. So here's the Omnibus Bill that I was talking about. I told you a little bit about it, but I didn't go through it. So there are, so where you want to go is section 301 to 308. And these are related specifically to telehealth. So they are expanding the originating site so that it includes the patient home. They are expanding the practitioners that can furnish telehealth to include your OT, PT, and SP, and audiologists, so that they can provide those services if you have those service lines. They are extending the ability for the FQHCs and the RHCs to be a distant site provider for that 151 days. They're extending the coverage of that audio telehealth only services, especially mental health, but this is across the board. And then they're also extending the ability to use telehealth services to meet that face-to-face, recertification requirement for hospice care. And then, the idea of this is they're extending the exemption for the telehealth services, and that goes into how you can charge that, how you're going to bill that, how you're going to be reimbursed. And the other thing that this says is that they're going to require Medicare to give utilization reporting, and that has to be public, and they have to put that out. I don't think CMS has a problem with that because they've already been doing it. And I think that's part of what they're supposed to be doing, but everything that I'm reading shows that Medicare is fully supporting if there's going to be, they're fully supporting it. Interestingly enough, going back to the original rule, just so that you all know this, is that they the federal regulations say telecommunications. They don't clarify if that's audio or audio visual. There's no term for that. There's no definition. It was Medicare some time ago who said it had to be audio visual only. And so that's a caveat that they put in there. But now Congress is coming back and saying now it can be audio visual. So the idea of this is there's a couple of things. This is good news for us because we've got to figure out, do we need to, ramp up and operationalize, I'll get that word out in a minute, telehealth services as a new line of service that is going to be here permanently. Do we need to figure out what an exit plan is? How are we going to let our patients know? How are we going to get that information out to them? Or do we take a pause? Okay, we know it's going to come back. We're waiting on Congress. Do we pause our services and then move forward? So at least knowing that when the PHE ends, that's when the clock starts ticking in terms of that 151 days. We have 5 months to figure out what we're going to be doing. Hopefully, even before the PHE ends, we're going to have one of these bills in place. It's going to mean we're going to revert to the permanent new law, not the pre-law. And so we're still waiting to see what that's going to come out. Another thing that's going to be in here, just so that you know, is that for those mental health, right here in section 304, it's that 152 days past. So where CMS has said, we're going to require that you have a 6-month face-to-face before you can do it, and you have to have one annually, they're actually going to postpone that until 152 days. So after that, then the 6-month in-person requirement will come into play, and the annual visits will come into play. I'm sorry for the confusions and that there has been some update. You know, this is just coming out as we were putting the slide deck together. Does that answer everybody's questions? Did that? It was a good question because it helped me realize there was a slide that I needed to make sure I got to you all. Okay. All right, so we've talked about this and we've talked about that, this, and we've done that. This. Okay, so now we're on telehealth visits. So broadly speaking, when we look at the states here, what we can see is, you know, Alabama, you do allow live video. Currently, it is not covering telephonic visits in Alabama. So your Medicaids or anything that's going to be on that level. You do allow, or Alabama does allow for patient monitoring. And there is no payment parity law in place right now. And basically what that parity law means is that they require your private payers, commercial payers, to pay you at the same level as what CMS will be. So there is going to be some changes in that. And I think also we're going to see some changes in the federal law that says, because right now what it says is telecommunications can be paid up to this fee schedule. And I think it's going to actually change to say to be paid at fee schedule. And so with that, I think we're going to see that commercial payers are going to come along and realize that they have to follow this parity law. So, but currently Alabama is not saying, hey, commercial payers, you have to pay at the same amount. For Arkansas, we are running into the same things. They do allow for the live audio. They're not allowing the telephone calls right now. There are private payer laws that exist, and then they allow for patient monitoring, and then they do require consent as well. And then the payment parity law, no payment parity law, again, what can be paid. Louisiana, running into the same thing, live video, but your Medicaid or your state doesn't have a law to cover telephone visits currently, that is. And then so for the same thing, private payer laws do exist, and then allows for patient monitoring and requires consent, and then no payment parity law. And Mississippi, you're under the same kind of umbrella here. I will tell all of you that I expect that this will be updated and changed. We've seen, you know, Medicare say, hey, this is real, this is working, we want to keep it. We've seen Congress say, hey, Medicare, you're saying this is good, we're going to pick up what you're laying down. And so we're going to start making some, at least some temporary laws to make it happen. I do expect that our state laws will then start following suit. They're going to see that the clinical evidence is there. We know that this is helpful. Who suffers worst is the patient in terms of not having this kind of access to healthcare. And so I do expect that these laws will be updated as quickly as they can update these laws, or we're going to see temporary bills being passed until they can get the law changed. So stay tuned and, you know, stay abreast of what those changes are going to be. Here's our originating site. Again, that's the Q3014. So if the patient is physically located in there, you want to make sure that you're billing out that originating site. It's around between $20 and $30. It's a little less than $30 is what it's reimbursing. So for the RHCs, you're going to bill that out on the UB04 with revenue code 780. And then, or you might be billing it out on the 1500 with place of service 02. And then for your independent physician clinics, you're going to bill it out on the 1500. Place of service is 11, and you want to put the Q3014 on that. Hospital is going to be on a UB. Type of bill is going to be 12X, whatever it's going to be. Your type of service is going to be 9. So your other services, whatever that's going to be. And then you can put that 510 for the clinic for your revenue code. And so then depending on what is going to be paid under your Medicaid, but Medicare is right around that $25, $26 range. Your Medicaids may pay a little bit more or less for that. So this code is still going to be available if you have your patients coming in. Some patients don't live where they can have, they don't have internet yet. So they still have to come into a site where they can have a safe visit with their patients. So don't knock this out yet as a patient access a service that you provide. Each of your states, they still are going to maintain a list of eligible services and codes that have been expanded for your telehealth and audio only and virtual communications. This has actually not changed pre-COVID, during COVID, and post-COVID. This still should be happening. Currently, we can have medical covered. We have our behavioral mental health, and who can do those case management and making sure that you're doing that. Dental services right now, there's some of those that are still going to be allowed to be telehealth and therapy, and then school clinic services again can still be done telehealth if necessary. So understanding how to do that. These would be specific ways that need to be reimbursed. As you saw in the chat box, if you need help with these specifically, reach out to the team here and we'll get in touch with you and make sure you get the right information because it's too specific for all of the states. So I wanted to go back into, because I can tell you that even now, as I'm working with some of the folks, they don't understand what a distant site practitioner is versus an originating site practitioner. So I did want to kind of step back, kind of do a 101 on that and say, okay, hey, for making sure that understanding distant site, it's not just that you're the provider and you're over there, so you're the distant from the patient. It's also if you're eligible to be that distant site. So pre-COVID, RHCs and FQHCs are treated like a facility, so they cannot be a distant site provider because they're a facility-ish. So during COVID, we were allowed to act as FQHC and RHCs are able to act as a distant site provider because you have clinicians and practitioners and doctors and they can provide these services and the patients at home. So that's during COVID. Post-COVID, we have the 151 days. So if you're FQHC or RHC, you can still be a distant site and for that 151 days, unless they pass another rule, another law that says that it becomes permanent, which, to be honest, I think we all expect. We just haven't seen it yet. And until we see it, it's not there. So, and the exception to this is also mental health. Once the PHE ends, once that 151-day extension ends, mental health is seen, the definition, what Medicare did, they changed the definition. And that if you do it either by telephone or audio visual, that it is a face-to-face. And so that's how you build that out. So mental health would be separate than that. Mental health is okay. We're good once we get out of the PHE. So just understanding where you are at in the timeline can be good. We still have the virtual check-ins currently, the G10 and 20. This has not changed since COVID. This is still available to you. And then the E2012, the e-check, currently these are still available services to you. Here's something specific. Again, this hasn't changed. Looking at Arkansas and Mississippi, Arkansas, you're going to report the 2012 or the T1015 place of service 2, and then your revenue code, the 2021 modifier U7 and GT. Whereas Mississippi, you're going to report the G2015 and place of service 2. It's paid under the fee schedule. Again, you can see from state to state how these can become very cumbersome to figure out who's doing what where. So make sure you reach out for those with questions. Consent. Patient consent is still going to be required. Making sure that you're documenting that during COVID. We still have it. It should be in the physician or practitioner documentation. We should be able to see it right there in the note. It needs to be in big red crayon what's going on with that patient and that they agree to both audio and visual. Currently, without any change of permanent law, we would revert back to pre-COVID laws where there's that much more stringent consent that needs to be done prior to the service. So making sure that you understand that and making sure you're getting those consents in there. And how are you going to add that layer back in if the rules don't change? Because we right now need to be ready to revert backwards. I haven't seen a whole lot of updates in terms of the consents and what's going to be allowed, but right now we do know that we want it in there. And they're still using those terms, especially like if you look at mental health, it can be audio only if the patient doesn't consent to the visual. So, they're still using that language and they're still pushing that. So don't let that fall to the wayside in terms of getting the consents in there. We do think that this is going to be an audit area because it is a risk area. Sometimes a physician or practitioner just forgets. I mean, you're there to take care of a patient. And so just think of it as, I'm getting ready to do something to this patient. I need to make sure they're okay that I'm going to do it. So make sure that you're checking in on that. Documentation criteria, once more, when we're looking at this, make sure you've got the type of service. Tell us what it is. Make sure you're documenting that. Is it audio only? Is it audio visual? Is it an e-check? Make that as big red crayon. Now your EHRs will have peripheral information that will show that. And when you're looking at it, you're like, oh yeah, I know what this is. What you have to think about is if a auditor came in and said, your payer came in and said, send me that record, what you're going to send is just that note. Is it clear in the note what's going on with that patient? What kind of visit is it? Is it in the header? Is it, is a physician documenting it? Making sure that that information is coming across big red crayon again, plain sight to the payer. Location of the patient and the rendering provider. We are recommending, because when you read these regs, when you read the physician fee schedule, they're using terms like home, skilled nursing facility, FQHC, RHC, hospital. We have seen that some of the EHRs are having you put down an address and they're not really saying that the patient's home or the patient's, at the at the McDonald's parking lot, or the patient's at the hospital. And so think about our place of service. We have 2 and 10 now. You're either home or not at home, but also you might have to be in a skilled nursing facility, or you might need to build the originating site. So getting your physicians to say where the patient is so that you're able to make sure those things are getting billed right, or your counterparts. So if you're the distant provider and you know that this patient's at a hospital, that hospital is going to bill that originating site fee. So make sure that you're saying that the patient's at a hospital so that if the hospital is audited, it's real clear. It's at the hospital, and so that's the originating site of it. So, helping out each other in terms of this and reimbursement. Names and roles of any ancillary staff involved in the case, of course. Make sure your orders are there and available, so making sure you're sending those. Medical necessity for the telehealth or virtual services, and then the rendering provider. Same documentation requirements as if it was a face-to-face. Okay, so I do want to step back. Are there any questions? There's a lot of things, and and everybody, again, grace to everybody. It is changing, understand that your Medicaids, your states, your governors. I mean, I've been through reading this and watching everything that they're going through. So not just are they handling telehealth, they're also handling the National Guard and, how's work going to be? Our legislators right now are taking on a lot. So we have to give them some grace, but then we also have to let them know we need to know how to do it. And so, letting them know that these things are going on, but I think things are going to change. I do believe the writing is on the wall. And this is Heather speaking. I do believe telehealth is here to stay. I do not think it's going to go anywhere. When you read the information that CMS is putting out, we already know that audiovisual or telehealth in general is reducing readmission rates. So for those of you in the hospital, having that telehealth call, doing that transition call, those things are actually reducing your 30-day readmission. That's great for your quality scores. So, making sure you do that. They know that it's also reducing the amount of time it's taking a patient to recuperate, because they can ask immediately if something's not going right, or they can say, oh, by the way, should this be read? Oh, no, it should not be read. So let's go ahead and start antibiotics right now, instead of it being read and icky and yucky. And you can tell I'm not a practitioner, right? And so, and start antibiotics, 10 days later. We all know that the sooner that we can start an antibiotic and stop something from happening, the easier it is to recover. So we know telehealth is working. We know that is clinically valid. So looking at your services, what you're providing, what has CMS said what services can go on for 2 years. We know we have those. There's about 60 codes, I think, that you can go in and look at. What are you doing now? How do you need to change your work process and your operation of those services, so that you're taking advantage of that. And honestly, when you look at that, what you're allowing your patient population to take advantage of. The idea of this is that this is truly going to help our patients. It's going to give them access to healthcare that they otherwise did not have access to. And that's the biggest thing. And I think for all of us, it's probably our underlying mission, or we wouldn't be in what we're doing. And we want to make sure those patients are taken care of. So with that, any questions, anything that we have?
I don't see any in the chat, but we do want to just, you're open to, if you're able to unmute, and we would love to hear your voice as well. Or just a reminder to use that chat function that's at the lower panel of your screen. There is a button for chat, and you just type on in there. So while folks are finding those buttons, we would like to start our polling questions. Again, we'd like to, Caleb will pull those up. This time there's 2 questions for you. And so we'd like to compare your knowledge gained. So the first one is going to be very similar to where you started, but we'd like to know now your understanding of the updates that were made to the telehealth billing and reimbursement guidelines due to COVID-19 public health emergency. And then the second question, if you scroll on down there a little bit, is how you will apply the knowledge gained from this training to improve your organization's telehealth billing and coding processes. So while you're doing that, and we'll welcome any questions or comments from you all. And just a reminder as well, Kate has put in the chat, again, that link for that ITA process if you do need some one-on-one coaching, as we have talked about, as Heather's talked about, as I've talked about. This is a big topic area and a very important one, and the center, or the Delta program, can help support you with furthering that education as well. So there's several of us on the call from the center. I see Shannon Sari, I see Nick, I see Kate, myself, and Caleb. So if you don't know how to fill out that link or not familiar with that, reach out to any one of us, and we'll be happy to get you connected with the right folks and the right process. So we're very excited for this opportunity. All right, so it looks like we have folks are now confident and somewhat confident That's excellent. Excellent. And they will confident they will use this knowledge to further to improve their organization's healthcare billing and coding processes. So we're very excited for that. All right. Wow, I can't believe there's not more questions. Now's your opportunity.
I can, when I'm researching this and watching it, I think Paula's on the call. She'll know that I've been doing it because I'm thinking and speaking in run-on sentences. It's like, okay, but yeah, but then it's here, and then but no, it's here. So there's a lot of information in there, and there's a lot of layering, and so we just you kind of have to break it up and make it work. Hi, Paula, I see you.
Well, we, as you know, we can always get back in touch with Heather if you do think of something, because as you said, it's a lot. And so I do some of my best thinking just in the middle of the night sometimes. So if something comes up, reach out to any of us and we will be happy to relay those questions back on to Heather. And Heather, we thank you so much for being here today, all your diligence and hard work in researching and studying to get this information to us. So we're very thrilled for you and your expertise. And we thank you all for joining us today. And so we'll be doing this next week, next Thursday, same time. And we'll be doing the second part, which we will be talking about specifically Tennessee, Illinois, Missouri, and Kentucky. So again, you're welcome to come back and hear the information again, but the emphasis will be on those 4 states the next time. But again, we're super glad that you all joined us today. And we wish you a great rest of your day. And if nothing else, we'll see you possibly next week.
Thank you for letting me partner with you. This has been a joy. I've really enjoyed it. Thank you.